Let's go to something different now. I was advocating for surgical intervention. Now I'm going to be advocating for endovascular intervention for major disease processes like the thoracoabdominal aneurysm. These are my disclosures. They haven't changed from my last talk, but I'm still open if someone wants to talk to me. So if we look at the history of aortic aneurysm management, originally we started obviously with popliteal ligation. Then we thought we could try and thrombose it by putting wires, and actually that didn't work. And so then they tried putting electrical current in the wire, which I don't think we could get through our IRB right now, and that didn't work. And then they said, here's the one where they'd actually filled the whole aneurysm with wires. And then we wrapped it with cellophane wrap, and we all know how that didn't work for Albert Einstein, where he died of a ruptured aortic aneurysm. Then we went to excision and grafting, and then exclusion and grafting by passing around it. Laparoscopic era, we dabbled in doing a laparoscopic repair. And then we got the EVAR issue era really in 1990, and that really is how we've kind of grown from there. And then we go into deep branching procedures, and then finally snorkels, chimneys, sandwiches, and fenestrated and branch grafts as we look at the endovascular options. As I said, open repair of the complex thoracic and perirenal aneurysms. It's maximally invasive surgery. You have significant blood loss, much higher mortality, higher incidence of pulmonary renal dysfunction, and a prolonged recovery period. This is a patient that we did with open chest and abdomen. You can see the large aneurysm we come through, diaphragms taken down, viscera's retracted. So obviously recovery from this type of procedure is extremely long. And I remember one of my patients, I thought had a great result from his thoracoabdominal aneurysm until he told me at a 6-month follow-up, he finally stopped hating me for the pain it was from recovering from the thoracoabdominal aneurysm repair. If we look at the results of this, you're going to see kind of on all comers about a 10% paraplegia rate for open repair, 11% renal insufficiency, and a 7% mortality. And those are the best centers numbers as you go through, obviously, Dr. Safi and Caselli's groups. So if we look at the management, juxtarenal and thoracoabdominal aneurysm, debranching, physician-modified fenestrated grafts, fenestrated and branch grafts. A lot of the branch grafts now are being done by Dr. Schneider and everyone that has the IDE for doing it. The parallel grafts for EVAR and TVAR and Chivas, which was being done and has now been pulled off the market or low enrollment in their trials. Here's a patient with a 7-centimeter aneurysm that we came in. This is early on, and we actually did a debranching procedure where we did a bypass to celiac and SMA surgically, and then put endografts going above. So here's the retrograde mesenteric bypass, just a 12x6 graft. Went home in day 10, and then came back and we placed an EVAR above her bypass graft, and then was able to exclude her aneurysm, and she had great flow. And for at least until I left Columbia, she was still doing well. Physician-modified grafts came up next, and this is where we actually created holes, fenestrations, and branches on already made grafts. And here you can see where we've actually burned with an eye cautery a hole in the graft, used a 30-millimeter snare as our marker for it, and then sewed that on, then recaptured the graft and used that as our conduit for repairing the aneurysm. Years ago, I had an 83-year-old woman that came in, Jehovah's Witness, absolutely categorically refused any blood transfusion, and she'd been worked up, diagnosed while being evaluated for a GI complaint, was found she was seen throughout the eastern seaboard, and everyone refused repair. And then she presented to us with severe abdominal pain, back pain, and multiple medical problems, as you see listed here. We came in, and it's a subtle little aneurysm. As you can see, it's really 7.5 by 13 centimeters in size, really pointing right to the anterior abdominal wall. And you can see in our 3D reconstruction, multiple areas of aneurysmal degeneration involving the distal descending thoracic aorta and the abdominal aorta. With this, we were able to come in and actually rebuild her with a back table modified graft. We saw there's good filling for the celiac branches from the SMA, and she had a chronically occluded proximal celiac. Here's the back table modified grafts being made, and there we're showing the radiopaque marker on it, and then repacking it. And there you can see as we put it through those markers, the covered stent grafts going to the SMA and then to both renals. We did have, you see we crossed through the renals as we come through as we were delivering these stent grafts. And then we basically rebuilt her entire aorta after we reconstructed the perivisceral segment down to the iliacs and up in the descending thoracic aorta. And as we built up, we were able to totally exclude her aneurysm. She had minimal blood loss and actually left the hospital, I think, by day 4. She has continued to do well, and she was followed up at least for a year after our first repair, and had continued with no endoleak and no aneurysm sac expansion and pain-free. So I think there's certainly a way to say that these patients can be treated even though they're with high morbidity and high complexity. We looked at the Medicare database, looking at endo versus open and the outcomes, and this was done about 10 years ago. And what we found is there's a pretty good match in demographics as we looked at the two Medicare cohorts. Their comorbidities were very similar throughout. Their complications postoperatively, those that had open repair, you can see that they had a much higher complication rate with everything except for device malfunction. Yes, the Dacron grafts do work fairly well. We then came in and looked at long-term survival, and the people that had the endovascular repair actually lived longer in the first 3 years than it normalized due to their comorbidities after about year 3. Propensities match was even more telling. We saw a significant advantage for those patients undergoing endo repair compared to open repair. Fenestrated grafts here was first used in the late 1990s and now is used worldwide. You can have multiple small, large, or scallop type of fenestrations as you come through, and the scallops can be very varied in size from 6 to 12 millimeters in width, in diameter, and you're trying to get a good sealing area within a normal, healthy section of the aorta. Here's an example of the different fenestrated grafts where you can have at the lower right corner here, you can see the small fenestration. This is the large fenestration here, and this is the scallop. We then orient those for the different vessels as we're doing the reconstruction. Here's a case presentation. One of the early patients I treated, again, he had an aneurysm really going right up to the left renal. We were able to come in with a fenestrated graft and maintain perfusion in the left renal, land in the more normal section of the aorta, and then put branches to the other renal and the SMA scallop. Parallel grafts, chimney, double barrel. Here's where you're basically putting 2 grafts or sometimes 3 up to 5 going in the same direction, but really kind of laying outside the main aortic graft. And this is a way of maintaining perfusion to the visceral vessels, but still isolating the aneurysm sac itself. Sandwich is where you put these parallel grafts between 2 layers of aortic graft. And we looked at the number of grafts and their impact on the main body, and we found once you got over 2 parallel grafts in one location, that tends to lose some of the aortic domain and cause thrombosis, so I tend to only use 2 parallel grafts at any one level. The Pericles registry really kind of showed that it's a safe and efficacious treatment for patients with perivisceral and perirenal aneurysms as well as thoracoabdominal, with about a 50% reduction in major complications compared to the original data I presented to you for open repair. Their follow-up, again, you can see that the follow-up going out to 17 months. The 30-day mortality was 5%, which, as you recall, was over close to 10% for the open repair. 4 procedurally related deaths. They had a 1.7% stroke rate, and their type 1A endoleak was rated about 8%. So here's a gentleman I'll go through quickly that was transferred to us from the Dominican Republic with a tender aortic aneurysm. He jumped on a plane and showed up in our ED. He had been taking some performance-enhancing drugs, and he had a significant hypertension and then ended up with an aortic dissection, as you see here, starting just beyond the just at the level of the left subclavian, and then you can see it dissecting all the way down through the abdominal aortic component involving the visceral vessels. And then he had an infrarenal aortic aneurysm that was 8 centimeters in size as you came down. And there's the area of dissection really extending right up to the left subclavian. So we can do this in a staged approach. We did intervention where we came in and we did an angio, actually came in and identified that the flap was very mobile, as you can see here under the endovascular ultrasound. And so we did, let me go back. We did a left carotid subclavian bypass, and then a left subclavian artery embolization, and then a thoracic aortic endograft. Here you can see where we embolized, and then we ended up rebuilding all the way down, and then parallel grafts to the visceral vessels, and then bifurcated graft to the aortic bifurcation. So by doing these endovascular techniques, we've been able to really help treat a lot of patients that weren't considered good candidates for open repair. And I think it's something we need to consider for all these patients as we give them their different options. Thank you very much.
Thank you, Jim. Our next speaker is Dr. Ajit Rao from Mount Sinai Hospital. He's going to speak about the indications for surgical and endovascular treatment of type B aortic dissections. I'd like to welcome Dr. Rao. Thank you.
All right, thank you. I have no relevant disclosures. So I'll be talking about type B dissections, so distal to the left subclavian, as we all know. So we can break these down into uncomplicated and complicated. So uncomplicated account for about 55%. And traditionally, the teaching has been medical management. So that's with strict blood pressure, heart rate control, and surveillance. Complicated comes in a bunch of varieties, including rupture, visceral, extremity malperfusion, aneurysm, or patients that have persistent ongoing pain. And typically and still the teaching is, and the data is to treat these patients with a TVAR and then any sort of adjunctive procedures to treat the ischemia or malperfusion afterwards. So I think really the kind of interesting area of dissections is the quote unquote gold standard of these uncomplicated type B dissections is when to treat them, because about 20 to 50% of these patients with uncomplicated type B dissections will go on to have aortic-related complications, including ruptures, aneurysms, and so forth. And so identifying those patients is critical. So what are the kind of goals of therapies for these uncomplicated dissections? It's really to promote aortic remodeling by really false lumen thrombosis to prevent aneurysms and rupture. So I think kind of a good summary of kind of this ongoing research in areas. So I have this 63-year-old female. She initially presented with 3 days of worsening chest and back pain, came in pretty, in typical fashion with hypertensive, ongoing chest pain. So we got a CTA. So here you can see what actually looks like a thrombosed dissection versus intramural hematoma that starts at the subclavian and goes all the way down to her celiac. So this would be defined as uncomplicated pathology. So she was treated conservatively with blood pressure control. Her pain actually got better. But then 1 month later, she came on with chest pain, came back with chest pain, which I knew was a concerning sign. And here you can see left pleural effusion, as well as kind of this kind of flow back into her false lumen versus like a little saccular aneurysm there. So she was hemodynamically stable. So she was taken for a carotid subclavian bypass because that went to her left subclavian, followed by a TVAR and angio with IVUS. And so here are just some photos. You can see the Amplatzer plug in the carotid subclavian bypass. And here's a better view of that. And so I think we used a Cook alpha here. And we extended down to the celiac, the full extent of her unhealthy aorta. So the key is really to identify which patients require intervention. So there's been some trials. So the INSTEAD trial looked at TVAR versus best medical management. And at 2 years, they failed to show kind of any survival or kind of adverse event improvement with TVAR compared to medical management. Then after that, the INSTEAD XL trial came out looking at, I believe, 5 years, and they actually did see a improved aortic specific mortality. So compared to best medical therapy, TVAR had a 6.9% aorta-specific mortality versus 19.3%. And I think even more kind of striking is the remodeling, which was almost 80% with TVAR versus just medical therapy. The Absorb trial was another research paper that came out, which did show long-term favorable outcomes with endovascular management using TVAR compared with best medical therapy. So all these trials kind of beg the question, so which patients do we treat that are uncomplicated? And there's been a number of studies that have come out, and even the SVS has posted some guidelines. And so these are kind of the risk factors that we think may promote degeneration over time of these type B dissections. So the number of vessels originating from the false lumen, aortic diameter over 4 centimeters. So I think that's a big one, and that's something that I use when a patient initially comes in with an uncomplicated type B dissection. Large false lumen, a large entry tear over 10 millimeters. Refractory pain, I think, is a good sign. Pleural effusion, entry tear and the lesser curvature. And then a patent false lumen or a partially thrombosed false lumen versus a completely thrombosed false lumen. So I think when you see these patients come in acutely, these are some things that you should look at carefully in the CAT scan to decide whether to treat them. I also think the other extremely important caveat to that is when to treat them. So dissections can be divided into time periods: hyperacute, acute within 2 weeks, subacute to up to 90 days, and chronic. And really, again, this is a fine balance. So patients that come in the acute phase, one of the kind of dreaded complications we worry about with TVAR is a retrograde dissection with that fresh kind of dissection and tear in the aorta. And so those patients, unless they have some sort of acute complication, really should be managed medically if possible for the first 2 weeks. On the other end of that spectrum, though, is those patients with chronic disease. So their dissection and kind of septum starts to get more rigid, and it may not expand as well. So if you've ever seen these dissections on IVUS, when you first place these stent grafts, in the beginning it's very mobile flap, and then when you look at it months apart, it's really kind of a fixed flap. So finding that balance is key, and I think right now the subacute period has been shown to be the most promising with the kind of best of both worlds. And of course, we want to treat patients with a good life expectancy, because uncomplicated dissections, we're really talking about years in terms of the survival benefit based on the data we have. Surgical management of aortic dissections, just briefly, as Dr. Mckinsey and everyone talked about, these are much more morbid procedures with higher rates of complications, so you really need a good risk candidate. I would say a lot of times now it's reserved for failed endovascular management, so if they have a persistent endoleak after an EVAR or TVAR, if there's some sort of extremity malperfusion, so in a hybrid approach, so they come in with a type B dissection and you place a TVAR and the malperfusion to the extremity doesn't improve. Some of us will do a fem-fem bypass. And then obviously chronic dissections with thoracoabdominal aneurysms as well. So this is another case that was a little more involved. So it was a 72-year-old. She actually came in initially about 5-10 years back with a type B dissection. She ultimately got a type A dissection and was treated with a total arch replacement, as well as visceral debranching for kind of a rupture in her aorta. So that was done in the remote past. She was lost to follow-up for about 10 years, and then she came back with intermittent chest pain. So here you can see on your CAT scan the total arch there, and then what was left of her native proximal descending aorta. And then this is where they did the debranching farther down. So here you can see this kind of large kind of saccular aneurysm and ulcer, which was symptomatic. So for this patient, we took her for a TVAR. So here's her aortogram. And so here we deployed a Cook alpha just basically up to her arch or her arch vessels. And so we actually had a good seal. So she did well for a year, and then a year later after that, she came back with new CTA findings of these horrible looking aneurysms in her visceral segment from the debranching site. So clearly she has some underlying undiagnosed connective tissue disorder, and I think that's kind of, one of the things that we can look forward to kind of research more into these patients, identifying genetic predispositions that may promote these degenerations over time. So she was referred for an open repair, and here's just an angiogram showing that. So in conclusion, I think uncomplicated type B dissections, even though the traditional treatment has been conservative management, up to 50% will degenerate with aortic specific related morbidity and mortality. So I think identifying high-risk features and factors should be considered before deciding to intervene. TVAR in the subacute setting has been shown to be done safely and can promote favorable aortic remodeling. Thank you.
Thank you, Dr. Rao. That was an excellent talk and excellent overview on type B aortic dissection management. Our next speaker also needs no introduction, Dr. Daniel Hahn, who's one of the co-directors of the aortic program being held tomorrow. He is going to speak to us about managing aortic complications. Thank you.
Good afternoon and thank you. We have an esteemed panel, so I thought I'd spice up your afternoon with a disaster case that gave me emotional turmoil for a bit. Rather than go through some slides, I'm going to kind of go through a slide and open it up so that the panel and the audience can pick it apart. These are my disclosures. We have an 85-year-old male, history of hypertension, hyperlipidemia, COPD, and then history of ascending aortic aneurysm status post bioprosthetic AVR and ascending aortic replacement in 2002, who developed some fatigue, had worsening dyspnea on exertion. The TTE and TEE showed severe aortic stenosis of the bioprostatic AV, so the patient was going to go with structural for TAVR. The pre-TAVR CTA showed kind of a steep aortic arch, but overall looked okay. Diameter looked okay. Access vessels looked okay, so the patient went for a TAVR. No aneurysm, no evidence of dissection. The TAVR reportedly went very fine. Bilateral percutaneous femoral artery access on the right with the 14 French, on the left with the 6 French, and left femoral vein access, and they put in a Medtronic Evolute Pro. Per report, no difficulties in actually getting the device up over the aortic arch. Final distal angiogram showed patent iliac arteries without dissection, and perclose was used in standard fashion. Post-op day 1, patient starting to complain about severe lower back pain, was ordered for a stat CT angio. And here's the CT angio coming down. Oh, yes, that's the reaction I was hoping to get from you guys. So you can see a pretty bad dissection that starts from the aortic arch that comes all the way down. If we let this kind of cycle through one more time, if I can do that successfully without not messing this up, one of the other features to note is that the true lumen, it gets completely collapsed. This smaller one in the posterior side is the true lumen, and it's completely collapsed going all the way down to the iliac vessels. With celiac, SMA, and right renal are supplied by the false lumen. Yeah, we'll talk about that in a second. And I'm curious to later, when we talk with the panel, whether or not this is a portion that you would have gone straight to the operating room or not, and I'm open to take some suggestions for that. We opted to put this patient in the ICU with aggressive anti-impulse control, and the patient's pain started getting a little bit better, and it looked like they were doing okay. You just heard a talk where you don't want to rush to the operating room a lot of the times in these cases because you're worried about a very unstable aorta where you can things make substantially worse. Post-op day 3, we made it to post-op day 3. He had really bad chest pain, became hypertensive to systolics of 160s and became lethargic, and that's the chest x-ray from that morning. Horrible. Clearly, something doesn't look right. The H&H was stable, but we obtained the CT angio, and within the course of 2 days, that aorta had evolved into something that looked like this. So once again, you see a hematoma up that ascending arch. You see intramural hematoma going all the way down. That true lumen, once again, was significantly compressed coming all the way down. Now, despite the true lumen being compressed, there were no signs of malperfusion, even on that post-op day 1. The creatinine was relatively okay. The patient was not having abdominal pain, and the lactate was okay. And as you can see, this is a horrible, ugly-looking CTA. Here's it from another view. You can see the TAVR in place, and essentially the hematoma is going to come all the way down through this length of that aorta. Well, this one cycled through as well, extending all the way down into the iliac system. So at this point, I think everyone would agree, you cannot wait on this. This one goes to the operating room. When we went to the operating room, these were going to be our goals. Number one, we saw intramural hematoma going all the way up, essentially to the subclavian artery, arguably beyond it. But in this acute setting, the goal was going to be to cover the aorta as much as possible to as healthy as possible. So we were going to cover up to zone 2 and cover the left subclavian artery acutely. Even before we even talk about all that, this was going to be a challenge. The true lumen was completely collapsed, going all the way down into that system. So we're worried about it. The goal here versus regular kind of type B dissection is different. This is a ruptured aneurysm, so we need to achieve some cessation of flow into the false lumen, even if it's there. So we have to try to minimize that flow. We have to plug that subclavian artery, and while we're doing all of this, remember 3 of the renal-visceral vessels came off the false lumen, so we've got to make sure renal-visceral perfusion is maintained. So we went in trying to do this, and access was challenging, but with a lot of help. This is the true lumen, and this is what the angiogram in the true lumen looks like, because the true lumen is so decompressed from a highly pressurized false lumen, and consistent with what we had seen, only the left kidney comes off the true lumen. Everything else was coming off the false lumen. Terrifying kind of angio, but we were able to do it. We were able to manipulate our way all the way up to the ascending arch, and we put up a Lunderquist wire. We confirmed the true lumen location all the way through on IVUS. You can see a very mobile, relatively mobile, I guess this is a terrible IVUS clip to show a mobile septum. It was a very mobile septum that was very collapsed and was still moving pretty substantially well. And you can kind of see this hematoma going all the way up to that subclavian artery, which was consistent with what we had seen on the CAT scan. We performed a TVAR covering the left subclavian artery. This was first, most of the time, in these kind of cases, I cannulate the subclavian artery and embolize it first, but the goal was to try to cover as much of this as quickly as possible to make sure the patient doesn't get unstable. So we covered the TVAR all the way up to the left common carotid artery using a slightly oversized slightly oversized TVAR graft. Typically, for dissections, we're not oversizing more than 10%, but this was also a rupture, so I oversized a little bit more. In addition, the patient had an ascending repair in the past, so I was a little bit less concerned about a retrograde type A dissection, and I wanted to make sure I achieved the seal. Now, distally, we always talk about don't balloon in an acute dissection, but I felt in this kind of scenario, we had to achieve good true lumen expansion and try to create a slowdown of flow into the false lumen, because that's where the actual problem was. So we performed a Knickerbocker at some point in the mid of that TVAR so that we could try to expand that TVAR as much as possible. And then we came from a radial approach and plugged that using coils. And then the completion angiogram, thank goodness, showed all the vessels still being perfused with both vessels. So at this point, we decided we're not going to stent or do anything to the visceral vessels and hope that this was enough. And when you see the completion angiogram, you see contrast coming down, but even in delays, you did not see significant contrast coming backwards. So we thought, all right, maybe we're out of dodge. So here's the repeat CT angio. It was a rupture. It's our standard practice to get a repeat CT angio for ruptures. And unfortunately, it didn't look as good as we thought. Pretty good amount of contrast that's still coming up into that false lumen. You saw some expansion of that TVAR graft and that mid-thoracic aorta. But when we got this immediately post-op day 1 after the TVAR, we didn't think this was an acceptable result. And I'm curious to hear more panelists' thoughts about this, but we felt that in a ruptured aorta, this was way too much of a blush that we're seeing in the area. So we decided to take this patient back to try to limit the amount of flow that's going into the false lumen. And the goal was going to be to embolize the false lumen, Knickerbocker a bit more, and take the TVAR further down to try to get as much cessation of flow as possible. A couple good things when we went back to the operating room, the true lumen had significantly expanded. I'm so sorry, I don't know why my IVUS images look so terrible here, but the true lumen had significantly expanded compared to the first day, which we were happy with. We were able to cross over from the true lumen into the false lumen through one of the renal-visceral fenestrations that you can see over here. You hear about a lot of different false lumen embolization techniques, including candy plug. We did not want to put something so big in the false lumen in a very acute setting. So we had opted to do an Amplatzer plug. There's 2 side-by-side Amplatzer plugs along with some coils in the back. We extended the TVAR further down, closer to the celiac artery, and then we Knickerbockered a little bit further more, all of this was an attempt to try to minimize the amount of flow. And I think our completion angiogram, you can see the blood going down to the true lumen, coming retrograde, and stopping pretty much at the plug and not going backwards. So during all of this, luckily, the patient was relatively stable. Here's a follow-up CTA that looks perfect. Unfortunately not. It doesn't look perfect, but I think it was a result that we were able to accept with significantly diminished flow in that false lumen compared to what we had before. And then circulation going into all of the renal visceral vessels. I'll let that cycle all the way through again so that you guys can nitpick it a little bit more. So if we have that come back through. Resolving intramural hematoma, pretty decent wall apposition, coils along that false lumen, and then all the flow through that segment as well. So summary of some of the techniques that were used for this acute aortic complication. We had to do proximal TEVAR extension to zone 2, left subclavian artery embolization, false lumen embolization, which I really haven't had to do in an acute setting such as this, but it was something that was necessary in this patient with the rupture, distal TEVAR extension, and then other things to do cessation of blood flow into the false lumen. So I think this kind of case highlights a lot of kind of thoughts about endovascular management of acute dissection and rupture in these patients. So I'll open this case up for your review. Thank you very much.
Dr. Han, thank you so much. I'd like to open up the floor for questions to our panel regarding any of these presentations, including the complex case that Dr. Han just presented. I'll start off with a question for Dr. Rao. You mentioned complicated and uncomplicated type B aortic dissection and indications for management with TEVAR. Do you feel there's such a thing as a truly uncomplicated type B dissection?
I think that's a great question. I do think we've all have had dissections, type B dissections that are uncomplicated. And you have that patient that you follow for years and it never changes. And then you have that patient that you follow for a few months, if that, and it starts growing. So I do think there are patients that will have a stable type B dissection that won't degenerate. And kind of like what we're alluding to is identifying those patients that won't degenerate and that is important to figure out who to treat. But I do think there is a subset of patients, a significant portion that will stay stable over time.
A follow-up to that. So are there certain criteria that you would say, all right, these patients definitely should be watched and are really not a good candidate, or not that they're not a good candidate, but that they really shouldn't offer early intervention in a specific cohort?
Yeah, I think that's a good point. I think number one is life expectancy, right? You're treating ideally late complications of dissection. So if you have a sick patient, or like Dr. Han's patient that you probably don't want to operate on, I think trying to observe and treat conservatively is a good idea.
So just a question for Dan. Dan, what do you think was the mechanism of this dissection? And why do you think it extended to the degree that it did and continued to grow for those of us who don't take care of these kind of complex cases?
Yeah, I think, and this is a question I actually would love to open up to the panel. So it's a patient who clearly is immediately after instrumentation of the aorta. So I think a lot of the times we treat iatrogenic injury to the aorta a little bit differently than regular standard like hypertensive type B dissection. I don't know the mechanism. It might have happened during the procedure or not, but I think you have comments.
Yeah, so unfortunately I've experienced this. And the thing that's unique to the thing that's different about the Medtronic TAVR system compared to Edwards is that, we spend a lot of time figuring out how to carefully go up and over, but you also have to be careful coming back. So when you come back, if you're not careful and you don't take the device and go gray to blue, you can scrape the aorta. And so you're scraping the aorta in the descending portion. And so you're creating a dissection. And I had a patient with that. Luckily, she had a very contained dissection, but what you went through, was our greatest fear, is that it was going to just start to extend. So it was probably from just closing the capsule on the TAVR and just scraping the aorta and creating a dissection.
Yeah, we've definitely seen it. I've seen a few of them. I think if I had to, I think the tortuosity in that case, if you look at that aorta, is quite tortuous. And so then you're passing the valve through. That tortuosity, I think, is a risk factor. But it's kind of hard to pinpoint one exact,
I guess my question for the panelists is, in that situation, you get that CAT scan post-op day 1 after TAVR, would you guys wait, or would you guys take that patient to the operating room there and then?
Well, if I knew what the 3-day CT scan was going to look like at day 1, I definitely would have taken them on day 1. But no, I think we all want to see if they're not having symptoms. I mean, pain that gets better with blood pressure control and things like that certainly makes me want to let them try and mature a little bit and declare themselves for what they're going to do or not do. Now, if you get any symptoms, and I think most of us with that very, very small true lumen would like to know that we're going to be going to do something. But if we're doing it at day 6, 7, I think it's very different than doing it day 1 before it's really had any type of time to stabilize. Not having the ability to look in the future, I would have done what you did and watched it and it made. Now, if they had continued pain with blood pressure control or they showed signs of any type of lactic acidosis, ischemia, et cetera, yes, I'd go forward. The 3 vessels coming out of the faults, I really wouldn't have been as worried about, because I think once you put your stents in, more than likely you're going to recover the perfusion there. I would like to have mapped out where the septal fenestrations were, so to know how much I could cover before I lost perfusion to the false lumen.
Yeah, this is definitely a unique patient population. I mean, you're dealing with a patient with severe aortic stenosis. They're high risk. I mean, we've actually even had focal type A dissections in the ascending that we just watch. I mean, in some ways, you have the TAVR in place, you have the valve in place, and it acts like a scaffold. It protects the sinotubular junction, and may even prevent, retrograde rupture or cardiac tamponade. But it's certainly a high risk population. Sam.
Dan, thanks for sharing that case. Quick question for you. It looked like the fenestration that was filling the false lumen was around the renovisceral segment. So what was going to be your plan if your coils didn't work or didn't stop the flow up to the level that you had coiled?
Yeah, that probably put more stuff in, I guess. Like it's either Knickerbocker in that acute situation or plug the false lumen. I guess you can talk about stenting and taking a covered stent further down and doing some sort of parallel grafting all the way down. But I really thought that was too much in the patient who was acute. And the goal was to try to, put a, I guess, Band-Aid on the problem for the time being. I don't know. Do you have suggestions, Sam?
Right. I mean, I think that's a good approach. I was just looking at that case trying to think what I would do. And so my thoughts would have been to, I think essentially what Dr. Mckinsey was talking about, map out where those fenestrations are. Obviously, you're going to have a higher risk of complications with more aortic coverage, but covering the fenestration is the problem. I mean, your patient's obviously high risk, but I think a parallel graft, in an emergent type situation, if you're familiar with that, is an option there.
I actually received Dr. Gray at Columbia. He came through and he was just putting an 8-French guide in, dissected the whole aorta all the way up. So it can happen. I mean, and that's the thing. I mean, I don't think, Cyclagov always used to say you can't dissect a normal aorta. Well, this is proving that even though you don't see, significant disease, these are, as our aortas get older, they're not normal anymore. And, it doesn't take, we just need to get that one little plane and up it goes.
Dr. Mckinsey, you spoke about endovascular aortic aneurysm repair and treating infrarenal and suprarenal aortic aneurysm repair. And now, between TAVR, aortic arch branch devices, thoracoabdominal branch devices, iliac branch devices, I mean, where do we go from here? What do we...
That was the last minute of my presentation. They said we were going to have 1 minute extra. But, I think that we're going to end up going to a TAVR arch graft somewhere down. We're figuring out how to keep the coronary perfused and everything else. And, people much smarter than I will come out with this. But we're really going to go from the valve all the way around. I think we're certainly going to be able to take off and through whether it be changes in permeability of the graft or whatever, do selective branches to each one of the main visceral vessels. You and I are doing one in a week as part of the GORE trial, TBE. And so we're moving more and more. Arch, we're definitely going to have endografts going all the way around. working with the valve, you can replace that and keep coronary perfusion. Then it becomes, now you're really basing on something that's got a lot of substance to it. So I think in the interim, we have to kind of appeal to our cardiothoracic surgery colleagues that when they're doing these type A dissections, do a hemiarch. Don't just do a little tube graft, so that we can then build down further as it needs, because these patients are going to need more work done. But the technology is definitely getting there. TAMBI, I think, is going to be a great way of treating 4-vessel grafts as we come through off the shelf. That's, we were phase 1, you're principal investigator for that, in phase 2. And so I think we're going to definitely see technology like that coming forward that's going to be off the shelf, that we can really treat a lot of these patients.
Yeah. I think we have one more question. Sardar had his hand raised earlier.
Regarding the possible mechanism of this dissection, could be also that when we go for valve-in-valve, we try to fracture the valve, the prosthetic surgical valve. This might be also the mechanism of the dissection. This is one thing which is very important to be noticed. And I always wonder when we do valve-in-valve TAVI whether we should do an angiogram after completion of the TAVR, including the entire arch, to see possible mechanism of
I think the one thing with TAVR is you always have echo, right? And so not all these patients get transesophageal echo, but if it's a high risk case and patient's intubated, transesophageal echo would be able to pick that up real well. All right. Any more questions, Jim? Any other questions? Should we take a coffee break? All right. Enjoy your coffee. Thank you.